Hi, everybody. Welcome to our keynote speaker portion. We have a very special speaker for you today. Long before the pandemic hit, healthcare workers were suffering from moral injury. Today, our keynote is actually doing a research project on the subject, so you all will be participating in that. Scattered throughout her presentation will be polling questions. Please pay close attention so you can be part of this important study. Professor Patricia Pittman is the Fitzhugh Mullen Professor of Health Workforce Equity at the Milken Institute of Public Health of George Washington University. As a director of the Mullen Institute for Health Workforce Equity, Professor Pittman built an extensive research enterprise focusing on policies that enable health workforce to better address health equity issues, including protection of labor rights of healthcare workers. She has published over 50 peer-reviewed articles. She has most recently worked on a background paper commissioned by RWJB for the new National Academies of Medicine Committee on Nursing 2020 to 2030. Professor, thank you for coming on with us. The stage is yours.
Thank you, Debbie, and it's such a pleasure to be here with you all today. Let me pull up my slide. Are you all able to see this? Just a thumbs up from Debbie. Hopefully we're all good. So I wanted to talk to you all today about, as Debbie said, a project that's ongoing is about moral injury among nurses. And we actually did start this study before the COVID pandemic began. But what I want to share with you today is largely the background. What is it? I think it's really important to define moral injury, why it matters, and what we can do to reduce it. I'll share some of the preliminary results, but largely I want to give you some terminology and some evidence that led up to this project. Let's see, there we go. So we're going to start with just a quick poll question before we even talk about what moral injury is. If you could just do a yes or no on whether you've experienced moral injury in the last year. The picture sometimes is worth 1,000 words, and I'm sure many of you can relate to this picture. So as you're thinking about whether or not you have, in fact, experienced moral injury, I wanted to give you some background. In 2019, the National Academy of Medicine actually acknowledged that the personal factors, the individual factors that relate to burnout are only a very small portion of the drivers of burnout. Of course, the term burnout has been used predominantly by employers to describe a situation in which people are exhausted. And so obviously, you know, the healthcare workforce has increasingly, as COVID has evolved, become rather irritable, shall we say, with regard to this use of this term, because there's kind of an implicit blame game going on where the idea is, well, if only you were a little more resilient, you know, you really sucked it up, you wouldn't be so burnt out. And so it was really important when the National Academy of Medicine came out and said, actually, the system level factors are what are driving burnout. No matter how many mindfulness workshops or, you know, pizza breaks or whatever you're going to get, you're not going to shore up people with resilience and solve this problem. You actually need to address the root cause. So this was the framework that they used. And you can see in the blue sort of the individual factors, which obviously do matter, but they're a very small portion of what matters. What really matters is society and culture, as we're learning with the whole issue of vaccines and masks. Rules and regulations, organizational factors, learning practice environments, and healthcare responsibility. And all of that impacts clinician well-being, which impacts the clinician-patient relationship, which in turn impacts patient well-being. So this was really important. So one, personal factors are only a small segment of the drivers, and two, clinician well-being matters because it has a relationship with patient well-being. So this is sort of, these are the, you know, the great authorities in our country on medicine have concluded this. So really we should applaud this first step towards acknowledging the problem. In 2021, just this spring, of course, the National Academy of Medicine also came out with the Future of Nursing 2020 to 2030 report. And I just want to sort of point out that one of their chapters, which was actually one of the chapters that they decided to add at the very last minute because of COVID, is specifically around nurse well-being. And this, of course, could be extended to the well-being of other healthcare workers as well. But in this case, the report was focused on nursing. And I think that their recommendation, basically that all of the nursing organizations and employers use evidence-based interventions to promote nurses' health and well-being, especially as they take on new roles to advance health equity, is a recommendation that you all can use to advance this issue. The chapter itself has its strengths and weaknesses, but I think we should build on what has been done by the powers that be. They are acknowledging that this is a problem, so I think it's important to use this recommendation to advance the topic. So where were we before COVID? Obviously, there's some real structural issues here that do not have to do with COVID, and then we had the COVID situation. But even before COVID, more than half of nurses said that their health was not good. 40%, only 44% said it was good. The burnout rates were reported to be between 35 and 45%. Suicide was very high among nurses, and if you compare the suicide among female nurses to female physicians, it was 70% higher among female nurses. So physicians also experience many of these problems, but I think there's nurses experience it to an even greater degree. And of course, nurses and patient care assistants among all professions, according to OSHA, are the ones that experience the highest rates of violence of any occupation. And in the critical care units and ICUs, of course, you see especially high rates of violence. 80% of critical care nurses reported that they had experienced verbal abuse at least once during the past year, and almost half of all of these nurses had physical abuse or discrimination. I think COVID has been long and drawn out, and there are different phases, obviously, with different levels of effects on the workforce. But mid-COVID, which was about September 2020, was this survey, and this was a survey of all healthcare workers, not just nurses. The burnout rate had climbed to 54%. But of course, people describe and understand burnout in different ways. So surveys are always, have some leeway there in terms of what's really happening. What I found to be really interesting was the more detailed description of the problem. So emotional exhaustion, 82%, trouble sleeping, 70%, physical exhaustion, 68%, work-related dread, 63%, physical symptoms like headaches, 56%, questioning their career path, 55%, and compassion fatigue, 52%. So by mid-COVID, we had, really a crisis was underway. By 2021, a year later, the American Association of Critical Care Nurses reported in their survey that 66% of nurses were considered leaving their jobs, 67% were afraid of putting their family's health at risk, and 92% believe the pandemic will shorten nurses' careers. So the situation went from bad to worse. So I want to pause here and just throw out a few questions that I hope you all will find interesting as you reflect on your own experience, and then are able to see yourself in relation to the others that are participating in this conference. So in the past year, how often did you see something unethical in the way care was provided but kept quiet about it? How often were you unable to provide the care you believed was best for your patients? And are you considering leaving your current role in the next year? So clearly these first two relate to moral injuries. We'll talk about a little more. So take your time filling that out. We'll have more as we move along. So I think, what we're hearing, and I'm sure all of you are hearing the same, is that during COVID, a number of factors have been exacerbating the situation. The first is that nurses and other healthcare roles as caretakers at home is really affecting how they're working, and the risk of infecting not just themselves but of their family is very stressful. Obviously, the medical uncertainty around the treatment protocols themselves early on was very stressful. The role as a surrogate family for patients, particularly in the early phases when no visitation was allowed by families, Nurses and others have not forgiven employers for the furloughs in many hospitals and the PPE shortages. So there was a sense of betrayal by the employer, a sense of being disposable. Nurses and other healthcare providers are witnessing the huge number of deaths and increasing patient acuity, which obviously has an effect on their health. There's pay disparity with travel nurses, which is another sort of source of feeling betrayed by the employer. Anger at patients and families that believe the disease is a hoax, which we can describe as betrayal by the community. Rationing care in some states due to the surge, and of course the huge sort of moral distress that can create, and then the continued absence of mechanisms to report patient safety and equity issues. So these are the kinds of issues that are kind of layered on and creating a lot of problems. So, does all of this stress, does all of this injury matter? There is an abundance of research that shows that it is directly related to nurses' health, an abundance of research that shows that it's directly related to poor patient outcomes. And of course, we know that it has tremendous costs even for the healthcare employers, and data on how much it costs to replace a nurse, for example, ranged from about $44,000 pre-COVID to about $70,000 currently, although I have a feeling that that number is even higher as we think about the shortages that are happening across the country. So evidence shows that these issues really do matter for the workforce, for patients, and for employers. So how do we think about, I'm going to just put all of these in here. How do we think about, how do we talk about this problem? So the way that many have talked about burnout is using the definition provided by Maslish and Jackson. And the idea is that burnout is an outcome, and it has three dimensions: emotional exhaustion, depersonalization, which can manifest itself as cynicism or apathy, and thirdly, a low sense of personal accomplishment work. Moral injury is less talked about. The nurse researchers have been studying moral distress since the early 90s, particularly in the critical care setting. Moral injury, which is a concept that came from studying folks in the military, was really sort of put forth by Dean and Tabbitt, who are both physicians, in 2018, when they published an article in Stat that sort of critiqued the exclusive focus on burnout and said there's something else really important happening here, and we call it moral injury. And they define it as a violation of one's moral code by witnessing, participating in, or precipitating moral harms. It results from a betrayal of what's right by someone who holds legitimate authority in a high-stakes situation. It causes, and this is the sort of effects of it, distress, shame, and guilt, and can lead to physical symptoms. So just hold that concept in your head for a moment. I want to also define a few other concepts that are related but different, and then we're going to put it all together. So second victim syndrome, some of you may have know about, is something that has been studied in the context of nursing as well as other healthcare providers. It's also a sense of distress, shame, and guilt, so similar symptoms, but it results from a precipitating event involving a patient, possibly resulting from an error or a strong identification with a patient. So there's a sort of additional distress as a result of a particular event. And then there's secondary trauma stress, STS, which is something that is sort of not related to a single event, but is just the ongoing stress from bearing witness to traumatized or suffering people. Compassion fatigue is often associated with STS. It's the ability to empathize with people is reduced as a result of repeated exposure to others' suffering. So you can see how these two would be linked. And then the last concept I want to throw out, because I think it's useful to have this terminology when we talk about the problem, is mattering. And there's a whole literature around the idea that, basically it's really important to professionals that their opinion matter and that they're valued in the context of a team. And what we hear often from healthcare workers, in particular from nurses, is the perception that their opinion or their contributions are not valued, and that causes distress as well. So here is a preliminary framework that I have put together with my team that tries to kind of put this all together and begin to tease out what some of the root causes of these problems are, focusing again on the systemic issues and not on the personal issues. So I think we can all agree that burnout should be kind of classified as an outcome. And the originating sort of dilemma, I think, particularly in nursing, but also in all healthcare professions, is that healthcare professionals train and are educated for a social mission. And it's part of the professional identity to serve patients, families, and communities. And when they begin work, they encounter a reality that is largely oriented by business values. Whether the hospital or the healthcare setting is for profit or not for profit may not even matter, but the sort of business culture is very different than the professional culture and the professional identity. So this kind of clash of cultures that happen. And I think that some of these things are sort of moral in nature and not, and we'll talk a little bit more about these 4 categories. But obviously, this issue of profits over patients and healthcare workers' well-being is a big problem. There's just plain old poor management, which may not be about profits, just people who don't know what they're doing. There are issues around insufficient organizational resources, which may be beyond the organization's control, as happens during a natural disaster. And then there are issues of culture and context, sort of the societal context of the organization. All of this feeds into the categories that we defined in the prior slide. So there's the idea of moral distress, which is a lesser level of moral injury. So you have moral distress that then can transform into moral injury when it gets to the level of trauma. And you have this secondary trauma stress and secondary victim syndrome that also are sort of lesser. I think the secondary victim syndrome is a more exacerbated form of the secondary trauma stress, which is more general. And the idea is that all of these things can cause burnout and they interrelate with each other, but they're distinct, right? They're very distinct. So, a key question that we're asking in this research is what is and what isn't in sort of the drivers of moral injury? There's some things that are not moral injury. We shouldn't call everything moral injury, right? That's the point. So here's sort of the preliminary findings from the interviews we've done thus far with nurses. And sort of trying to categorize what people are saying. So these are the 4 items that we saw in the yellow bar. So some of these things we are hypothesizing are moral in nature and therefore potentially causes of moral injury. Other things are tremendously stressful and may create burnout, but they're not necessarily moral in nature. And this is something that one could argue, and it's very much a sort of a preliminary hypothesis, if you will. So we welcome your feedback on this. It's not that we know that this to be true. This is sort of inching our way along, trying to understand what's in moral injury, what's outside of moral injury. So the part that is probably easiest to think about are situations when the business culture is clashing with the social mission culture. So we could, in simplistic terms, call this profit over people, whether the people are workers or the people are patients. Examples of this include an insurance company denying care, maybe the entire unit of a hospital. Oncology, for example, could be denying care to Medicaid patients either explicitly as a policy or implicitly by just trying to figure out ways to punt them to other hospitals. The overdiagnostic and treatment problem, which I'm sure you're all well aware of because of the fee-for-service system, referring to low-quality providers that might be part of the system, even though they are known to be of a lesser quality than someone who might be outside the system. Plain old insufficient staffing, the safe staffing problem, the problem of mandatory overtime in some states. Thankfully, I believe New Jersey is not one of them, but there are many states where people are being forced to work overtime. And some of the administrative burden issues, which are really important. Poor management also has administrative burden. In other words, if it's just doing things in a way that's not smart. So you could think about it as being sort of overlapping in either of those categories. Poor workflow, some of the technology burdens, shift work, as we'll talk about later, is just really a problem in terms of people's health. And, creating financial incentives to sort of encourage people to work more hours than they really can do to maintain their health. And then, of course, this reliance on travel agencies could be attributed to simply poor management. The cultural level up on the right-hand side are all the things that are sort of derived from culture and history, but that also impact the dynamics inside the healthcare organization. So the one, at the very bottom is the one top of mind for everybody, the community mistrust in science and authority, which seems to be growing and can lead to abuse, and as well as just this sense that this crisis that we're living is really sort of at this point man-made and not a natural disaster. It's a cultural phenomenon, the resistance that people have to taking public health measures. But it's also things like, starting at the top of the list, team dynamics. So this issue of not mattering, and the idea that only a physician or a manager's viewpoint is important, the problem of bullying within and across staff, the issue of patient abuse of staff, the issue of different kinds of discrimination, and then this culture that I know you all are familiar with, of just sort of this compulsion to save lives at any cost, even if it leads to tremendous suffering on the part of the patient and their family. And then lastly, limited resources. So I think of this as, again, kind of a not mutually exclusive, but having a component of it that's mutually exclusive, which is largely around the having a shortage of resources, of stuff, whether it's staff or devices or whatever, that because the demand has overwhelmed the supply, and it's not necessarily the fault of anybody. There's not necessarily a betrayal involved. And that would be the case, for example, if a hurricane hits, or perhaps in the early stages of COVID, when we thought about it as a natural disaster. People pull together and can kind of put up with this stuff if they know that no one is to blame. The limits of science and treatment options is another thing that people can't necessarily control at the healthcare organization, and they don't necessarily feel that that's a betrayal. The social determinants of health that create recidivism. You could blame the government for that, and probably we should, but it's not necessarily the hospital's fault. Space limitations, shortage of medications, technologies, et cetera. So this is a way of sort of thinking about all the drivers that are sort of system and organizational level, some of which tend to be more have a component of betrayal by legitimate authority. That is something that we're positing has a particularly detrimental effect on nurses and other healthcare providers' well-being, and is distinct from the other kinds of causes of burnout. So I want to pause here and throw out a few more questions. This is sort of presented to you in a Likert scale, so in a 1 to 5, with 5 being the highest level of agreement. Whether you agree with this statement. Limited resources and staff are making it impossible to provide the best care to patients. My professional opinion is ignored at work. My employers need to generate profits, has led me to do things I'm uncomfortable with. So we'll come back to these questions at the end and talk about what they mean. So I want to talk a little about just what evidence there is about what works and what these causes are. I would say that there are little pieces of evidence here and there, but it's not pulled together in a framework the way we're trying to do in the prior slides. So let me tell you what does exist in terms of evidence. We know that administrative burden and technologies are a double-edged sword. In particular, we know that the burden imposed by clinical documentation and other clerical tasks is causing burnout, and the need to redesign clinical documentation processes is well established. We know that there's alarm fatigue, missed alarms, and inappropriate parameter settings that can lead to patient harm. So this is an example of how technology can actually do harm, as well as obviously in other situations benefit. And then issues around infectious agents, needle sticks, slips and falls, and injuries due to standing, bending, and lifting patients can be addressed through technology. So technology can be both kind of a benefit and a harm. A lot of work around the problems of shift work. About 79% of newly licensed nurses work 12-hour shifts, and about 44% are working night shifts, and 61% of nurses were working overtime weekly prior to COVID. The implications are that the high demand, low control work environment and long working hours are associated with obesity. And of course, obesity is associated with higher risk of occupational injury. 40% a 40% increase in cardiovascular disease among shift workers. 32% of night shift workers and 26% of rotating shift workers have a long-term insomnia. 16% are at risk of a sprain or injury for night shift. So just keep in the back of your mind as we think about ways to improve nurse well-being, the issue of shifts are really important. Nurses working weekly overtime increases the risk of needle sticks by 32%. We are well aware of the issue of bullying and incivility. About half of nurses experience bullying and incivility in the workplace. And just to differentiate, the idea of bullying is repetitive, while incivility is a single episode perpetrated by a person of power. So just to try to help use these terms in ways that are precise and help us understand the problems. A few more little fragmented pieces of evidence. We know, obviously, that nurse staffing levels have been associated not just with poor patient outcomes by the work that Linda Aiken and her colleagues had done over the years, but that it's also associated with occupational injuries, including musculoskeletal injuries and disorders. We know that race matters in COVID, in the exposure to COVID. The early surveys showed that of 213 nurses that died, 31% were Filipino, and among hospital healthcare workers, more than 50% were Black. This was still in the early months of 2020, but the data has been pretty consistent as we've gone along. The issue of accommodating patients' preferences regarding race, gender, religion is a problematic one because of the adverse effects that it can have on the clinicians themselves in terms of feeling discriminated against. This is also an issue for LGBTQ+ nurses and nurses with disabilities who are reporting discrimination. And then the issue of microaggressions, which you could also call incivility, by employers, educators, managers, colleagues, and patients are correlated with poor health. So a pause again. Again, on a Likert scale, if you agree with these statements, my direct supervisor raises and discusses ethical concerns, i.e. uncertainty or conflict around the right thing to do. My direct supervisor communicates the reasoning, in other words, how and why, behind the decisions that have an impact on my work. And the employees in my work group do what's right, even if they feel it puts them at risk, e.g. risk to reputation or promotion, shift reassignment, peer relations, poor performance review, or risk termination. So I will move on here. So let's shift now sort of to the final part of my presentation, which is focused on solutions. And solutions are, there is no silver bullet to this. We know that we're likely to have sort of a multi-layered strategy, but I think it's kind of important to reverse the order that people generally think about things. So employers have focused a lot on building individual resilience to address burnout, and very little about organizational culture and practices, and almost nothing about public policy. So I think as we think about kind of a framework going forward for working on these issues, I'd like to reverse the order. Let's put public policy first. Let's put organizational culture and practices second. And lastly, let's think about individual resilience. No one's saying individual resilience is not important. It's just that it's been the exclusive focus to the detriment of the focus on these two other domains. And the NAM report that we talked about at the very beginning, the 2019 report, did conclude unequivocally that individual level interventions alone are insufficient. So we know this, we know this, we know this, we know this. Let's stop talking about these individual level interventions in isolation. What we need are integrated, systemic, organization-focused interventions, which are much more effective. So this is, in the words of the NAM, in the words of the great experts of our country, they have concluded this. Let's stop arguing about whether this is true or not. Interestingly, even the NAM report is very weak on public policy. It's mostly the organizational level, but hey, let's take what we can get. That was progress, and it's important to build on what has been sort of stated. So let me just say that a lot of stuff is out there focusing on resilience. These are a few of the initiatives that are underway. I don't in any way mean to diminish their importance. Again, it's just about doing more than just this stuff. So there are a lot of people working on resilience. Cinda Rushton at Hopkins, for example, there's a lot of interesting work about primary, secondary, and tertiary prevention that can help. There's a great project called the HNHN that ANA has that is about nurse health. Mindfulness appears to actually help a little bit with compassion fatigue, but there's no evidence that it helps with depression and anxiety. And then there's something called the Healer Evaluation Assessment and Referral tool, which is a web-based tool to sort of confidentially screen and refer individuals at risk for behavioral health issues. So just some examples of individual level kinds of interventions. Organizational level interventions can be focused on a lot of different things. A few things focused on racism and bullying have been studied. I think this first one is particularly interesting. So it's been found that interventions designed to reduce implicit bias are ineffective and may even increase implicit biases. So these workshops that we are all mandated to do are not necessarily the silver bullet that we'd hoped they would be. And everyone agrees that we need to reduce bias. The question is whether this actually helps. The single most important thing that the research has found in terms of reducing bullying and racism is speaking up. Speaking up if you're a witness or a bystander. And at the organizational level, having zero tolerance policies for verbal and physical abuse. And we know that in the surveys of critical care nurses, about half say that their facility have one, which means that half of facilities don't have a zero tolerance policy, and just 63% have it for physical abuse. So there's a lot of room to do better on these simple organizational policies, in conjunction with people just having the courage to stand up and say, this is not right. So focusing on the emerging sort of organizational level solutions, we got a lot of stuff here, and I don't want to spend too much time on each. IHI does a lot of work around the concept of joy of work, which some people have objected to because it sounds so Pollyanna-ish. These kinds of changes are not necessarily changes that are won simply by suggesting them. You may have to actually fight to have them implemented. So, the concept of joy is a bit contested, but at any rate, we know that the number one request and demand from the nurse workforce is to invest in staffing and to have minimum staffing levels to operate, if not at the organizational level, perhaps even at the state level. Removing these perverse incentives that encourage nurses to work more, which is dangerous for their health, and removing the mandates to work overtime. Having better flexible staffing, beginning to think about reducing the hours of shifts for those nurses that are in poor health or would prefer not to work those long shifts. Workflow redesign, of course. Mandates to break and acknowledge grief when a patient is lost. This is something that hospice nurses do on a regular basis, and I think the hospital sort of culture would do well to make this an internal policy. Mandating daily debriefs at the time that the team chooses, not at the very end of the day when people are desperately tired and needing to get home to relieve the babysitters. Access to confidential on-demand behavioral health supports like the HERE project I mentioned. Training for ethical conflicts and incorporating ethics committees and consultations. Training for team dynamics so that every team member's opinion matters. Preparing for and reporting violence. Requiring quarterly, this is an idea obviously that's new, but some hospitals and workers are agreeing that they need to do quarterly moral distress surveys, not just burnout surveys, but moral distress surveys that really get at the root causes. Making sure that there are whistleblower protections implemented internally, removing confidentiality clauses in contracts so people can speak up when there's a problem in safety, implementing protective assignment systems, and helping to train the leadership so they do a better job of putting themselves in the shoes of the workers and really listening. Some ideas about public policy, just to give you a flavor of the kind of thing we're thinking about. Schools should do a better job of training nurses and other healthcare professionals, in the case of other schools, for ethical conflict. What do you do when you're in a situation of ethical conflict? What is the protocol for standing up when you see something that's being done wrong? How do you think about the risk to your own career? And what kinds of resources are available to you to help shore up your courage and your protections and due process? Regulators, including the accrediting bodies that are overseeing nursing programs, should review what nurses are doing and encourage them to do more. So that's we have 3 accreditors of nursing programs. They are an important policy lever. The NCLEX test that is administered by the National Council of State Boards of Nursing, and any other profession would have its own licensure test, are an interesting and important policy lever. You can include things in those tests around ethical conflicts. And then, of course, healthcare organization accreditations should include ethical, review the ethical committees and the procedures around ethical conflict as part of what they do. Health plans could be doing more. We could be requiring them to do more. CMS, and recently I saw that the governor of New York also included in her executive order that was aimed at trying to shore up staffing in nursing in hospitals and nursing homes, the idea of eliminating prior authorization and reducing paperwork. This was something CMS did in the early stages of COVID as well. And I think everybody would agree that that's very helpful in terms of reducing administrative burden. And this is somewhat contested as folks think about moving more towards a value-based payment system. But to the extent that nurses do not bill for their services, they are often and almost always viewed as an expense and not a revenue generator. And so many have argued that what we need is CMS should experiment with some pilots that allow nurses to bill for services to see how that changes the culture of work in hospitals, and whether that might increase the prestige and the power that nurses have within hospitals, and put them more on a level playing field with other professions that do bill. State laws, you all are very familiar, I'm sure, with the whole question around mandating nurse to patient ratios, as they've done in California. Other approaches have been tried, including in New Jersey, of course, around mandating public reporting of nurse staffing ratios and staffing committees that are required to include frontline nurses. A study that I and my team just completed that came out in Medical Care a couple weeks ago showed that, fortunately or unfortunately, the only kind of law that actually seems to be moving the needle in terms of staffing levels are the mandates. That doesn't mean the public reporting or staffing committee laws couldn't become more effective if they were strengthened. But as they stand now, we looked longitudinally over a period of about 15 years. There is really no effect of those kinds of laws, those kind of alternative laws right now. So an interesting conversation to be had around what states can do with staffing laws. And of course, at the federal level, there's some discussion about whether there should be staffing laws as well. Other laws at the federal level, of course, the PRO Act, or to make it easier to unionize. There are federal laws that could be enacted around whistleblower protections, around due process if people speak out, and prohibition of gag orders, as we've seen a lot of healthcare workers have been laid off when they spoke to the press. So just examples of the kinds of actions that can be taken outside of the healthcare organization to incentivize, shall we say, if not oblige the healthcare organization to act in a way that is more conducive to having sort of well-being and avoiding moral injury. A lot of professional associations are doing things in this space. I think a lot more could be done. The American Association of Critical Care Nurses has an interesting tool out there called Healthy Work Environment that folks should look at if they're interested. They have an assessment tool for healthy work environment. ANA, ACN, in partnership with other nurse associations, have created a hotline with peer-to-peer conversations. Interesting stuff for sure. Apps for stress reduction, as we've talked about. This is more at the individual level, and don't mean in any way to diminish the importance of this work again, but really interesting to think about how these professional associations might leverage their power and their voice to look at some of the organizational and policy level changes that tend to be less front of mind. Okay, a little rest moment here. What's the most important thing that needs to be changed to improve your well-being? So we have a drop down there. If you have other ideas, we'd love to hear them. If it's not in the drop down, love to hear them in the chat and the questions as well. And I just want to stop with this slide. We are at GW partnering with AFT and with other organizations on this project that we call Moral Injury Among Nurses, Stories of Fractured Hearts and Wounded Souls. And it's really an effort to sort of put out a call for participation for nurses to help us collect stories. And we think about this kind of as a citizen researcher idea. Any of you could collect stories. You can tell your own stories. You can go to the website and upload your story, or you can ask us to call you and do a recorded interview. But you can also, there's a toolkit there. You can also collect your own stories from your colleagues and your friends who may not have the energy, particularly if they're feeling pretty beaten up these days, to tell their stories. So it's another way to sort of express your activism and to make sure that nurses' voices are heard. So I encourage you all to participate if you have an interest. And I think I will stop there. Our tagline at the Fitzhugh Mullen Institute for Health Workforce Equity is that health workforce policy is increasingly a health equity battlefield. So not for the faint of heart. And I look forward to hearing your questions and the conversation. Thanks very much.
Hi, Polly.
Hi, Debbie. Take it away.
So we have a question. Before I start with the results of the polls, we do have a question in the chat. Some people fail to recognize the signs of this syndrome until it's too late. Are there any telltale signs of an impending burnout?
Yeah, I mean, I think that there's a continuum of symptoms that are pretty well documented. And for burnout, there is, not for moral injury, right? We're talking about moral injury as sort of one of the ways you get to burnout. But burnout, there are burnout surveys that are very well established and tested. And there's kind of a scale that you can use. And I think it's publicly available. I put the citation in the PowerPoints, Deb, and you can certainly share the PowerPoints with the audience so people can find that survey. But there's a well-established survey. The moral injury surveys, you can see that we're kind of playing around with some questions, trying to get at it. And there's no established survey right now, but I'm hoping we're working with colleagues, including Wendy Dean and Simon Tavitt, to try to develop one that we think will be useful at the organizational level.
We have another question that says, how do you continue to care for your critically ill patients without disengaging your personal feelings, but keeping yourself adequately functioning while facing so much death? I mean, this is kind of like compassion fatigue, isn't it?
Yeah. So I think one of the added values of the concept of moral injury is, yes, you can have the secondary stress syndrome, which is sort of what you're describing by just witnessing so much suffering over time. But one of the things about moral injury that introduces sort of a different set of tools is that I think, when you think back on periods in history of extreme human suffering, like World War II, if you think about people who were living in Nazi-occupied France or whatever, what were the mechanisms they had to survive under such duress for so long? And I think probably the single most important phenomenon was, you could call it solidarity, you could call it social capital, you could call it moral community. People call it different things, but it's essentially collective kindness to each other. Peer support is, and some organizations have that in spades and other organizations don't. When your moral community is depleted, you are much more at risk. And conversely, if you are an employer that really cares about your employees, what you want to do is create opportunities for collective action. And this is really a concept that is not just workers against employers, right? It's actually something that could benefit both. If you have collective action and partnership, where you're working on these issues together, I think it helps tremendously to feel not stuck and not so depleted and powerless, because this is largely an issue of powerlessness, right? So, I think we should never underestimate, not to be cliched, the the power of kindness at an individual level. But if we can also step it up to a collective level of actions that are collective to help each other, in collaboration with the employer, or in some instances that's not possible, just among peers, either at the unit level, the organizational level, perhaps at the union level, perhaps at the association level. But those are actually reparative activities. They actually repair the human mind. If there hadn't been resistance in France, I think the resistance was as much about maintaining the mental health and well-being of a population as it was about actually being able to win. And you see that in many situations of people of refugees or of people who are under tremendous distress, that the issue of social ties and social capital is really, really important in the workplace, among your peers.
Thank you. And I totally agree with you. So we have another question that says, thank you for such great information. I'm not sure I understand this, but I'm going to read it out loud. Would you consider a lawsuit contributing to secondary victim syndrome? I guess being named in a lawsuit, perhaps?
Yeah, maybe the person could clarify, because the thing about secondary victim syndrome is that sometimes it's when there's an error on the part of the healthcare worker that causes that trauma. And so I'm not sure if the question is about a lawsuit against the healthcare worker or if it's about the healthcare worker suing the system, which is for having put them in the situation where they ended up making a mistake, which is an interesting question. I think, I have such mixed feelings about malpractice lawsuits. They are something that really do help consumers, but they also create a culture of defensiveness in hospitals that can be very perverse, and obviously has led to a lot of overtreatment of patients. So, bringing a law into the clinician-patient interaction is complicated, and probably a whole other presentation that I'm ill-suited to do.
Absolutely. I mean, we have a lot of lawsuits here in New Jersey. We have a pretty high rate of lawsuits here. And it is stressful. And I'm wondering if this person has been involved in a lawsuit and it is very stressful and contributing. It says contributing to secondary victim syndrome. It's possible.
Absolutely, I could see that. Yeah.
We do have another question. In various cultures, speaking up might not be something people are comfortable with. How do we as a union respect others' cultural norms and yet urge them to advocate for themselves as well?
Well, one thing I think that has been really helpful is mentoring and having a buddy system. So particularly for recent immigrants that may be coming from a country that does not have a lot of respect for nurses, vis-a-vis physician dynamics, for example, I think it's really helpful to have a buddy who helps in the transition, and as long as it's needed. We use in academia, which is also can be a brutal workplace environment, believe it or not. We really take mentoring of junior faculty seriously. And we also, for new employees, for my institute, for example, we always have a buddy who's kind of a peer, but maybe a slightly higher level in their career trajectory, even for students. And it's absolutely helpful, and it's especially helpful for recent immigrants who may not know their way around, the organization or the culture as well. And it's sometimes the pairing of the people has to be done. Generally what we do is suggest pairings of individuals. We have lists of people who are willing to be mentors or buddies, and people who need it. We believe that everybody needs it when they start. And I think it might be helpful, particularly for, I have a feeling that the American Hospital Association is going to try to visa their way out of this nursing shortage. So where there is likely to be a new wave of new immigrant nurses, and we know, particularly from India and Africa, that this is an issue, and it goes away after a couple of years. It's just a transition. But I think the American counterparts can do a lot to ease that transition and to support immigrant nurses.
I think, you mentioned one of the contributing factors as staffing. And I think one of the issues that we found as practitioners is that because staffing is not good in many of our facilities, those nurses who could be such valuable resources to newer nurses and nurses who require a mentor are so overwhelmed that they may not provide as much oversight and as much support as they could. I think one of the critical needs we have in our profession is for staffing legislation in order to be able to safely mentor, take care of our patients, orient other nurses, precept. It's a culture. And I recall seeing newer nurses who had no resource in the bathroom crying hysterically because they couldn't do what they needed to do. And they had no one who could support them because everybody was overwhelmed. We as a union are going to be focusing in a large way on staffing legislation.
I think it's just one further comment on that, Deb, which is there's a difference between sort of preceptor and mentoring for education and the other, which is more the social and cultural side of things. Mm-hmm. And I think it's probably good to separate those two roles. Mm-hmm. Just
Absolutely.
Because the education side is much more kind of like boom, 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 whereas the other is more listening.
Well, the bedside, when we're talking about mentoring, the bedside is where it becomes most challenging. A bedside practitioner trying to mentor another person while at the same time, juggling their own assignment it's very challenging. We do have a couple more questions here. How should one address the employer about continuous moral injury to a set population when this is their culture? Thank you for your transparency, it says. I'm not sure if that question is really clear. How should one address the employer about?
I'm wondering what the set population is. If they mean a particular segment of the workforce, or they mean a particular race or ethnicity, or an age group, or any other.
Or a set population of employers who aren't listening. I'm not quite sure either. If somebody wants to clarify what they meant by that question, we can move on to the
it sounds like
one.
It could mean something around structural racism, perhaps.
I'm not quite sure. I'm just looking at the questions without context. Let me go on to the next one, and maybe we can get some clarity with that one a little bit later. Are there any prescribed ways to deal with the gaslighting we see by employers regarding the concept of personal responsibility or self-care regarding burnout that really is generated by their business model? What would you say to that?
Well, that's the $1 million question, is sort of how do we make this change happen? I think it would be naive to think that this isn't about power. At some point, the conversations just aren't useful. One of the things that I hope this project will do is give us a vocabulary and an evidence base that is not as easily disputed, because moral injury has been defined in so many different ways. And there's kind of, for a while, people thought it's either moral injury or burnout. And so we're all like talking past each other. If we all kind of agree on a vocabulary and we create a little bit of evidence behind these things, then it makes it harder for employers to wiggle out of the conversation. And that's why I emphasized also the NAM reports. I think you should cite those NAM reports because they are done by, they're no longer just great white men, but, these are our nation's experts, and no one would dispute their conclusions and their recommendations. So I think you should use them when you can to establish authority, right? While it's not exactly what we want to be saying, it's a big step in the right direction. So use them, cite research whenever you can. I
Yes.
think on the safe staffing issue, the work that Linda Aiken did was extraordinarily revolutionary. It changed everything, right? We have evidence now that this is the case. And so where you can find evidence, use it. And that's why I also provided the citations in my presentation so that you can go and look for those citations if you want to use it. You know, we want to build an evidence base for change.
We have cited the Aiken report on multiple occasions. And I agree with you. We should use these studies wherever we can. We have about 5 minutes remaining in the session. We have a question here, but I didn't know if you wanted to go over a few of your poll questions or just.
Whatever you think, Deb, in the last few minutes. I'm happy to do the last question, but it'd be great to sort of talk a little about the responses to the poll questions.
Sure, absolutely. So I got screenshots of these, and let me tell you this. To the question of how often were you unable to provide the care you believed was best for your patients, we have a full 63% saying more than 6 times. That's significant. That was the highest amount as a choice. And I think you probably got these via text too.
Yeah.
When asked, are you considering leaving your current position? 27% of the responses said yes. That is significant when we are considering the nursing shortage we already have in the state. What do you say to that?
Yeah, absolutely. I mean, you know, we've probably lost about 25% of nurses on the floor already. So this is, I guess, an additional, you know, 27%. That's not insignificant. That would throw the whole healthcare system into crisis. There's no question about it.
And I believe we already are in a crisis. Limited resources and staff are making it impossible to provide the best care to patients. 58% strongly agree. I'm going to read one more question, but we don't have much time left. I have to say this. I want to refer people to your vendor site, your exhibitor site on the attendee hub. Please go under exhibitors, and you can contact somebody at the university. I don't know if this email goes directly to you, Polly.
It goes to my assistant, yeah. And I'm putting here in the chat our website, my Twitter handle, and my email. Whoops, I did my email with a comma instead of a dot, but somebody can correct that as you put that into the chat. I'd love to hear from anybody. I'd love to have you all participate in the study, helping us collect stories. Yeah.
So the site is the Fitzhugh Mullen Institute Workforce Health
Workforce Equity.
Thank you.
It's a Health Workforce Equity.
But it's under the site, the vendor site is Fitzhugh Mullen. Just look under Fitzhugh Mullen, watch the 30-second video. At the end of that video, you can email that particular site and go on that site to get more information and email Polly and her assistant to participate in this project. Polly, we will get you all the answers to the questions. This has been wonderful. Appreciate you being on our convention, and thanks so much.
Well, thanks to you for all the good work you're doing on behalf of healthcare workers, Deb, and I look forward to continuing the conversations.
Thank you. Take care.